Let me know when you'd like to start, Rodney.
Okay, let's get started today. Good morning, afternoon, or evening, wherever you happen to be. I'm Rodney Johnson, Managing Director of the KBLA. I'd like to thank everybody for participating today. We're happy to welcome all of our KBLA members, CanCham Korea members, and guest participants to our third professional seminar series event of the year. We've had a large number of signups, over 100, from Canada, USA, Korea, Singapore, and elsewhere around the world. So this event is being held in cooperation with the Canadian Chamber of Commerce in Korea. CanCham did an excellent job of getting the word out. We're very appreciative of their efforts. COVID-19 is certainly changing the world. It's changing everything. When this is all over, we may never go back to the way things once were, not completely. This even is a good example, this event. Events used to be difficult to set up. They required a long lead time of weeks or even months, and they entailed significant financial risk. You're now able to set up events like this in less than a week, attract a large audience, and offer it all on a complimentary basis. I think we'll find going forward that this is the new normal, digital, global, fast, cost-effective, and you only need half of your wardrobe. So I'm sure we could discuss this for a full day, so we probably will discuss it for at least an hour in an upcoming event at KBLA. We have some great seminars coming up in the near future. To some quick operational issues for today, we have a very large group. We'll have all the microphones muted. We ask you to keep your microphone muted, and to avoid any disruption and maximize bandwidth. There's simply too many of us to allow for raised hands or open mics, so questions should be sent as messages directly to our speaker or to the whole audience. I think Dr. Gurel has already set up a message there for the chat room. He will address the questions during the presentation or after as he sees fit and the presentation and time allow. I won't spend a lot of time introducing him. Dr. Gurel's greatly truncated bio is available in the announcement for the meeting. Dr. Gurel is an important part of the expat community here in Korea, and in his role of innovation ambassador, he's a very important part of the Korean Business Leaders Alliance. I think we'll all be very lucky to hear his insights today, and so with that, I'll turn it over to our speaker, Dr. Gurel.
Thank you very much, Rodney, and thank you for the opportunity to participate in this KBLA webinar, along with the Canadian Chamber of Commerce, who I appreciate also for organizing. And I thank you all for joining us, especially during this very difficult time. And as Rodney mentioned, I've opened the group chat. It's easy to communicate there. I might be even asking some questions and make this interactive. And certainly we'll have an extended discussion at the conclusion of the presentation. So see if you can find that chat room, and we'll engage there. Rodney, can you see my opening screen for the PowerPoint? Yes? Okay, so
Sorry.
This, thank you very much. So this is Korea's response to COVID-19, although the presentation will actually talk about the situation more generally and not just Korea's response. And at one point in the presentation, I'll also have Rodney interject with some of his observations on this important matter, particularly with respect to Korea, since he's a great expert through KBLA and his other work with Korea and risk management and so forth. So, as Rodney mentioned, we live in a changed world that goes way beyond the fact that we're all connected here now on webinar. There's a world before Corona, and with the Olympics being postponed, as everyone knows, stock market crashing, airlines grounded, social distancing, and of course, deaths rising worldwide. We now have a world after Corona. And as I'll point out in this presentation, this world after the Corona, AC, as one could term it, is not going to change very soon. And I'll point out ways that we have been trying to mitigate, is the technical term, or deal with the crisis at present, and some of the future outlook and how we may try to deal with it in the future, as this will not be going away very soon. So I wanted to give some background on the virus. So I apologize that we'll have a little bit of science here, but I think knowledge is very important and very explanatory. So the virus is essentially, it's termed SARS coronavirus 2. So it's related to SARS, and I'll talk about its relationship to the original SARS epidemic in 2003, as well as MERS, Middle Eastern Respiratory Syndrome, in 2015. Most of you are familiar with. There are important differences of the current epidemic. But as a virus, it's actually quite simple. This looks like a complex diagram, but it essentially has three components. One is on the surface, a spike protein, and this spike protein determines the target of the virus. This spike protein is also what is blocked by antibodies, whether those antibodies are generated by immunity from being exposed to the virus or through a vaccine. And this spike protein can also be used for testing or detection of the virus. The second component of the virus is what's called an envelope, which is essentially a lipid or fatty, greasy layer that surrounds the virus. This is extremely important because it determines the environmental stability. This virus, scary as it has been, disrupting life for billions of people around the world, is actually fairly fragile. And understanding how it's fragile in the context of this lipid membrane is very important for us dealing with that in a practical way. And I'll describe how that works. And the third component is inside the virus, and that's the genetic material. And this is the RNA. Most of you obviously have heard of DNA, but this is a different type of genetic material called RNA. And what's specifically important about this RNA as compared to DNA is it's quite mutation prone. And those mutations are also going to be figure largely in our response to the virus in a practical way. So this is science. This may sound abstract, but there are very practical consequences of this. In addition, some of the tests you may have heard, in fact, the most common test, the PCR test, is based on detecting the unique RNA in this virus. So spike protein, envelope, and RNA. And I show this picture here in the upper right, not gratuitously just to show a picture, but you can see the virus is slightly deformed in these electron micrographs. And why is that important? It indicates that this virus is kind of like, it's not a hard particle, but it's this fragile entity that can be squeezed, as you can see here. And that's by consequence of this envelope. So I have a question for the audience. You can chat your answers very quickly. Is this virus alive? You can just, all of you don't have to answer, of course, but just answer. So I see yes, no. I don't want to sound political, but mind you, I'm pretty sure the President of the United States doesn't know the answer to this question. So don't worry, you're not alone. So I see some yeses, I see some no's, I see yes and no. That's a good answer. Yes, no, not when outside the body. That's a good answer. Okay, so I'll just pipe in here. The answer is no, it is not alive. Although some people qualified it yes and no, etc. It only propagates, replicates in a host cell. Outside the host cell, it is essentially a physical entity. It is not living. And that's very important because there's a whole question of antivirals and the magic bullet. Everyone's waiting for that antiviral. I don't want to set the webinar on a negative note or be overly depressing, but there will never be a molecule or a drug that kills this virus because it is not living. And that's very important to keep in mind. In other words, if governments, if you personally, if CanCham or KBLA are waiting for that antiviral to come out and save everybody, it's not going to happen. That's because it's not alive. Now, you may say, well, there are antivirals there. The antivirals work by slowing down that replication once it's in the host so that the body can eliminate it through its immune system. So technically, the only way to get rid of the virus is to either physically destroy it, which we'll talk about, or to have the immune system clear it, which we'll talk about as well. Those are the only two definitive ways to get rid of this virus, and that's very important for public policy. So how do we destroy the virus? So as I mentioned, it's this RNA, this envelope, which is fragile, and this protein. So the four ways to destroy the virus are soap and water, because soap, as you know, solubilizes, dissolves grease, and that surface of the virus is like a grease. So soap and water are very effective. So many people have been talking about personal measures, masks, social distancing, etc. All of these play a role, but probably if you were to say, what is the single most important measure that you as an individual or your organizations can take, is to use soap and water and have that available. Related to that is alcohol hand sanitizer, which also disrupts this membrane. So it's not a physical hard particle. It is actually a fragile entity that are easily destroyed by soap and water and alcohol hand sanitizer. And I use the word destroy very specifically because, as I said, it cannot be technically killed. It can be destroyed. Three other methods which oxidize these proteins and also inactivate it or destroy it are bleach solution and hydrogen peroxide. So I personally obviously try to wash my hands. At my door, at the entrance, I have a soap and water alcohol hand sanitizer. I carry this around as well in a smaller form factor. And I also have a hydrogen peroxide spray that I spray in my mouth, something like this. So it doesn't necessarily smell good. That's not the point. We're all social distancing, so it's not about that. But these are the four effective ways to destroy the coronavirus. So now let's talk a little bit about the disease. So the disease is called COVID-19, and the target of that spike protein is in the lungs. Actually, it's throughout the body. But in particular, two types of cells in the lung are the type 1 pneumocytes, which are about 95% of this surface. This is the alveolus. This is the blood circulation, the capillaries. So air is here, blood is up here, and air is exchanged over here. So you can imagine damaging or infecting these alveoli is going to make problems with gas exchange. Now, 95%, most of these cells are these lining cells called type 1 pneumocytes, and only 5% are these type 2 pneumocytes, which express the target, which is this ACE2 protein. Now, what's interesting is many respiratory diseases, such as the flu, some other colds, some other respiratory diseases, I'm simplifying here, but they generally infect this epithelium, the type 1 pneumocytes, other respiratory epithelium around the respiratory passages. And the COVID virus affects only a small number of these cells. But it turns out that these small number of these cells are extremely important in your physiology. So even though it's a relatively small number of cells, which may also explain one reason why there are individuals basically are asymptomatic or don't suffer many consequences, the cells that are infected are extremely important. It's a critical vulnerability in the body. And that's one reason why elderly people, those with certain conditions, which we'll describe, including some young people, can suddenly decompensate and enter into a very difficult situation because these key cells are involved. Why are these key cells, which are only about 5% of the cells in the lung, so critical? They secrete what's called a pulmonary surfactant, which keeps these airways open. And when they are open, the gas exchange can occur. When they are collapsed, the gas exchange does not occur. So as I mentioned, in the lungs, this spike protein binds to what's called an ACE protein, angiotensin converting enzyme protein, on the surface of these type 2 pneumocytes. So that's the spike protein, the ACE protein. There have been a lot of articles, there's a lot of science behind this, especially indicating that people with hypertension, diabetes, cardiovascular disease have a special vulnerability. And that's one reason why is this ACE2 protein is not just involved in these pneumocytes, but is also involved in your fundamental balance of your blood pressure. So I'm not going to go into the details of that, but as this virus infects these cells, those cells are destroyed, which I said are very key vulnerability. And the ACE2, which helps with your hemodynamic or blood pressure balance, is also affected. So you get destruction of these type 2 pneumocytes, late stage inflammation, fibrosis. And interestingly, CT scans or x-rays can be very sensitive to this infection because it produces this out of proportion response in the lungs. So as I mentioned, there are many viruses that affect the respiratory system. And of course, the flu is very primary among them. And I think it's important to explain how this is different than the flu because a lot of those comparisons are made. For one thing, COVID-19 or the SARS-CoV-2 virus is more infective or more transmissible than the flu. So there's this so-called R0 number, which indicates that the number of people on average who are infected by an infected person is 1.3 in the flu. In COVID-19, it's between 2 and 3, which is quite significant. With measles, it approaches the double digits, about 15 to 20, so that's even more infectious. The incubation time is much longer. So people who catch a flu, you might have been around somebody who was coughing, and typically 2 days later, maybe the next day, you start to feel some symptoms, but the incubation time with COVID-19 is much longer. So this is extremely dangerous because it creates a longer window in which people are infectious. And indeed, depending on the circumstances, this R0 number may even be an underestimate. And then, as I mentioned, the flu infects a lot of cells in the body, but they're not as critical as the type 2 pneumocytes that I described that are infected by COVID-19. So the hospitalization rate is much more significant, 20% or so for COVID-19. And the case fatality rate, which is a controversial number, but I think it's fairly clear that it is substantially greater than the flu. We're talking about an order of magnitude greater than the flu, if not more than that. If you look at the current statistics that are being followed, there's an approximately 5% or 4 to 5% fatality rate. And the fatalities, as you know, lag the incidence of the disease. It takes some time for the disease to unfold. So those numbers may in fact increase, although there's also arguments that as we test more asymptomatic people, this number may decrease, but suffice it to say, this is not the same as the flu. So here's a big question. How is it that this virus is so transmissible, even though it can be highly fatal in some people? So somebody asked a question, by the way, how can you get an accurate fatality rate if you can't pinpoint when infection occurred in each individual? This is an important principle in medicine. The precise absolute number, I'm speaking as a former surgeon, is not critical to making a life-saving decision. These are often relative numbers or order of magnitude numbers. So if somebody says the fatality rate is 3.2%, not 3.5%, or if they say it's 2.5% and not 3.5%, and people start to argue about that, and then the politics come in, you know, that as a doctor is irrelevant. the reality is it is substantially greater than flu. What that precise number is, I'm not going to, as a surgeon, wait until we get that precise number while the patient dies. So I just want to clear that up. I know there's been a lot of politics on this, but basic understanding, basic education is very important with this. So appreciate the question. And I'll address some of these other questions. We'll have extended time for discussion, by the way, as we did in the last webinar. So here's a big question. SARS is so transmissible, but it can be highly fatal. This is another interesting concept in viruses. In general, and this is the good news, I'm sorry if there wasn't a lot of good news so far, but this is the good news. In general, viruses, they're not political. They don't take things personally. They don't want to kill people. In fact, they benefit from not killing people. They just benefit from transmitting, benefit being in genetic propagation or whatever. So actually viruses tend to mutate into a less virulent form over time. And this is a very important concept, but somehow SARS is both transmissible and fatal. Typically, we have a chart like this, where this is the case fatality rate. As I mentioned, the precise number is not important. We have 60, 40, 50, 20%, 0%. This is the R0, which is the transmissibility. Again, the precise number is not critical. As a medical doctor or as an epidemiologist, of course you want data, but you want to find trends and relative changes. So in general, you see a chart here, highly fatal viruses are less transmissible, more transmissible viruses are less fatal. And this is approximate again. So you have this negative or inverse correlation. So generally there's an inverse relationship. More transmissible, less fatal, less transmissible, more fatal. Where is SARS-CoV-2? It's kind of in the middle here. So it has, it's not I think Dr. Fauci was mentioning this. Ebola is very scary. It has a 50% fatality rate. You get Ebola and it doesn't matter, 50% fatality rate. That's very scary, but it's extremely hard to transmit that virus. You literally have to be touching and extremely close contact with Ebola. So SARS coronavirus 2 is right in this sweet spot, to use perhaps an inappropriate term, between transmissible and fatal. Just like its target is in this sweet spot or vulnerable spot with those type 2 pneumocytes. So there have been terms out there called containment and mitigation. So what are they? This is time and this is number of cases. This is the large peak here is with no intervention. A containment strategy seeks to basically limit this increase. We've known that around the world, containment strategy has been supplanted by a mitigation strategy, and that is this green curve here, which tries to push this out over time. So that is the mitigation strategy. Other people have called it flattening the curve. Now, what's interesting about this is that the fatality of the virus, and this is another point about fatality rate, in medicine, things are not in isolation. It's a highly interconnected ecosystem. So the virus as a particle has a certain property which we discussed, but the outcome of that property depends on the medical care that is in the system. In other words, if you have no medical care, that virus is very bad. If you have good medical care, that virus is less bad. So it's an interconnected system. So when we have arguments about fatality rates, it's assuming, people get the medicine, they get the ventilators, they have all this interconnected is working. But those fatality rates actually become irrelevant if the medical care is not there. And so the purpose of this mitigation strategy is not just to reduce the amount of infections, but to align that with the level of medical care that is available. And so the other term for that, as many of you know, is flattening the curve. So I would argue that we have these case fatality rates of 2%, 3%, et cetera, depends where. But all other things being equal, not counting mutation, which is another issue we will talk about shortly, if you don't have the ventilators, if you don't have the medical care system, that fatality rate is going to increase. So saying that we don't have the precise number is not helpful, even though we do want to get the data, is not a helpful sort of approach. So containment and mitigation. So another two terms that have been out there that are important to understand. One is quarantine and the other one is isolation. Quarantine is the separation and restriction of movement of people who have been exposed to the disease or have some risk factor. So typically early on, this was people traveling from affected areas. It might have been people that might have been expanded to people who had key symptoms like cough or fever. So it involves people who have been exposed to a contagious disease. Can be done in multiple locations, home or quarantine facility, etc. So quarantine is the unexposed people, I mean the uninfected people, but exposed. Isolation refers to people who are ill or have been infected. So medically diagnosed, typically done at healthcare facilities, although we can also have isolation because this is not always fatal in the home. The key point here is isolation cannot happen unless you have a method to identify the virus. In other words, you have to have testing. So if people are talking about isolation, but there's no testing, that doesn't make any sense. So we can have quarantine based on clinical indicators, a history, so forth. We need testing for isolation. Another very important concept that healthcare systems should be aware of is the difference between individual isolation and cohort isolation. So people have talked about isolation. Okay, those are the COVID patients, those are the TB patients, those are the measles patients, those are the polio patients. Let's just put them all in one facility. And since they're already sick, that's going to be okay. The problem is, as I mentioned at the outset, this is an RNA virus, and that RNA is highly mutable compared to a DNA virus. So this is a phylogenetic tree or a compendium of the different genome sequences of the virus. And in the 1918-19 Spanish flu, as you saw, people were piled up in these hospitals. That's not individual isolation, that's cohort isolation. And this is a shot of a Wuhan hospital. And as you know, the death rates went very high. This is the emergency room in Wuhan in China. And we're seeing similar cases in the United States where people are piled up on each other. That's not individual isolation. That's at best cohort isolation. Why is this a problem? Because the virus, as I mentioned, generally mutates not to kill people, but to be able to spread. And this genetic material, the value of the genetic material is its propagation. If the genetic material doesn't propagate, it dies out. But if it does propagate, that is self-sustaining. So killing the host does not benefit the virus. So generally, it tries to become more transmissible. The mutations will result in less fatality. There's one exception. If it's very easy to transmit, there is no pressure limiting that mutation. And mutations that increase fatality can more readily arise. So cohort isolation, or keeping many people together who have the disease, can result in successive replications that increases the risk of the mutation. The mutation for transmissibility is not selected for, but mutation for fatality arises, and you can get more fatal viruses. We heard cases of families being wiped out in Wuhan. We don't know exactly, but perhaps there was an increased mutation rate in that highly crowded environment. So it's extremely important that we consider individual isolation. Of course, if the healthcare system is overwhelmed and all we have is this situation, then that's the best we can do, but we have to imagine the consequences and deal with that. So what are the, there's a few questions. Why is the incubation so much longer for COVID versus flu? I don't think there's a answer to that that we know for definitively, but I can take a guess. As I mentioned, COVID doesn't, in the lung at least, doesn't infect cells, so many cells. So it kind of is a very low level infection. But there's a key vulnerability. So if that low level infection gets above a tipping point, then people medically decompensate. So it's simmering in a way. That's my concept, my understanding, and perhaps that's related to the incubation time, as opposed to infections like the flu that infect a lot more cells more robustly, and so that pathology manifests more quickly. So somebody asked, why do you need testing for isolation? Well, if you don't test and you're just guessing, that's not isolation, that's quarantine. So that may be a technical issue, but there are, as we're going to talk about with the mitigation strategies, the difference between quarantine and isolation is people definitely identified, but once we test, there's other aspects that are very important. Number one is isolation. Number two is a treatment. Number three is contact tracing. So if you're not going to isolate, if you're not going to treat, if you're not going to do contact tracing, then indeed, it's not very helpful to test. You just quarantine. But obviously, that's a failure of the system, and hopefully we can test. On a local TV show, I saw presence of diarrhea and stomach flu. So I wanted to address that point. These ACE2, angiotensin II cells, are actually quite common around the body. They are highly expressed in those type 2 pneumocytes that reflect a particular vulnerability, but they're actually in the intestine, in the upper respiratory tract, throughout the body. So this is actually a fairly low-level, widespread infection, but particularly targeting a key vulnerability. So let's go through some of these primary mitigation strategies going back to the presentation. This is that famous Imperial College study, which has since been taken off the web, but I think it shows some of this strategies quite nicely. This is peak demand for UK critical care beds will far outstrip supply even under the most ambitious mitigation strategies. So this is the ICU surge capacity, approximately 5,000 beds. And as I mentioned, these type 2 pneumocytes are critical to allowing people to breathe with their lungs. So if those are killed either by the virus or by the immune system, then people need a ventilator to tide them over. So here's school and university closure. The number of beds required is far outstripping the red line here. Home isolation for cases, assuming we can test, as I mentioned. Home quarantine for cases and social distancing. Household quarantine for cases. Home isolation of cases and social distancing. Focused on the elderly, throwing everything in. They feel that even if they throw all these measures that we'll talk about, we'll have 40,000 beds more than we used, more than we have. That's in the UK. So there are different, from a governmental level, different social distancing strategies. And this is actually Rodney's framework. He has organized this into 4 different strategies in a pyramid-like form. And I'll give it to Rodney just to go through this, 1, 2, and 3, and 4.
Well, the four options that you see here are the four options that are facing any country or even any organization, actually, in terms of stopping this outbreak as it comes from point zero to a full-on outbreak. It starts at 4. 4 is the easiest, the most preferred level that most countries would like to stay at, and then it works its way down 3, 2, 1. So a country can begin at 4, or it can begin at 1. It depends on the options that are available to it and the amount of planning that has gone in ahead of time. As with any crisis, the more planning that's done ahead of time, the more options that you can put away. And the earlier you react, the more options that are still remain available when it comes time to actually act. So an organization or a country like Korea, which had its first case on January 19th, actually reacted immediately. The very first cases were all imported cases, and those were people who had just come from China, and those initial cases began a testing program that Korea put into place immediately that allowed the country to remain proactive. And Ogan will talk, I'm sure, more deeply about the testing program and the entire strategy, but it allowed the country to become more proactive. So it was able to implement a strategy that kept it at level 4, kept it at voluntary social distancing with group avoidance. Korea didn't mandate closure of many facilities. It mandated closure of some. It recommended group avoidance. It recommended cessation of all group activities over a certain size. I can't remember what the size was initially. But due to a very aggressive complete program that it followed, it was able to remain at 4. If it had failed, it would have progressed down to 3, which is unenforced lockdown, which is where much of the world is today. And that's because it's they've actually either started too late and the option number 4 was already off the table, or even though they wanted to embrace number 4, the planning had not been done, the resources were not in place, and so it was impossible for them to actually enact that. If number 3 fails, which is possible in some countries and has already happened in some countries, you would progress down to number 2. China went directly from number 4 to number 2. It was very slow in getting started, but once it decided that it had a major problem on its hands, it went directly to number 2. It was able to succeed at enforced lockdown specifically because of the specific characteristics of the country. It had a culture and a political system and a crisis management strategy in place that enabled some of the measures that are required for enforced lockdown, such as increased surveillance of isolation cases, which I'm sure that we'll talk about for Korea as well. And so it was able to stop the outbreak in China. Even though the outbreak was initially very bad, it was able to stop it at some point. And if that fails, if enforced lockdown fails, then we end up by default into a herd immunity strategy where there really aren't any measures that anybody can do to avoid a larger outbreak in a larger portion of the population. So I know the United Kingdom and the Netherlands initially began by advocating for a herd immunity strategy, but later backed off it. So countries can certainly choose to do this directly from the beginning, but more likely countries that end up with a large percentage of the population being infected will have gotten there by first trying the other steps and other measures that are available to them. No one would really look forward to going directly to number 1 at this point, simply because the human suffering involved, the amount of people that would die, is estimated to be quite high. So that's it.
Thanks, Rodney. I want to mention one thing which will be important for later discussion regarding herd immunity strategy. It is in effect not a strategy. And the reason is, even though it sounds quite compelling, it's compelling because, as I mentioned, the only way you definitively get rid of the virus is through the immune response to that. And of course, there are two ways to accomplish that. One is that everyone just becomes immune through the so-called herd immunity strategy. And the second is through a vaccine. Now, the reason I say it's not a strategy is, apart from the human suffering that is going to ensue, as Rodney pointed out, if the purpose is to reduce the numbers or to prevent infection, it is not a strategy. In other words, it is essentially a do-nothing strategy. In other words, it is a strategy, but it's nothing to do with prevention. It's nothing to do with mitigation. It's nothing to do with helping anybody. It's just, it is what it is. Which of course then points, as I'll talk about later, to the definitive strategy, which is a vaccine. Thank you, Rodney. Before I go to the next slide, I wanted to answer a few more questions that popped up. Dan Cohen had mentioned about hand sanitizer killing, I should say, the word destroying, and of course being protected by the dermal layer and the alcohol evaporating. It's interesting, for alcohol to work, it actually needs to evaporate, and it's that process of desiccation that actually causes the destruction. So throwing alcohol and then keeping it wet and then spreading it around your face is not so effective. It actually has to be alcohol wet, then evaporate, and that process of evaporation desiccates that whatever's on the surface there. The other interesting thing is, I'm not going to show a slide about that, but there are indications that all different surfaces have different properties. So certain metals can have the virus stay viable. I won't use the word alive on its surface. Cardboard, other metals like copper don't allow as much viability. And so there's a lot to be said in the future for different sorts of surfaces that we may want to have that can ultimately limit that spread. It's not something that people ordinarily think about, except perhaps in a very specific medical or surgical setting, but it may be something to consider for the future. Another question that popped up from Lane is about the renin-angiotensin system and the virus throwing the blood pressure off in a serious way. Yes, so there are actually two vulnerabilities. The first one I was quite explicit about with reference to the type 2 pneumocytes and the respiratory function. The other thing is that ACE2 protein is involved in, and I alluded to this, the blood pressure control, and that blood pressure control goes awry. So there have been actually many cases of people where their blood pressure rises precipitously. In fact, with headache being a symptom, not the same muscle aches necessarily as the flu, but a headache from the hypertension. And of course, people with hypertension or cardiac situations will be especially vulnerable in that regard. And the third problem with this ACE2 is that ACE2 inhibits the tail end of the inflammatory process when the cells are repairing as a result of inflammation. And that repair process is related to fibrosis. So you may have heard about fibrotic changes in the lung happening much faster or more widespread in the case of COVID-19. And this vulnerability may also be related to that, although we're not entirely sure. So UV light can also destroy the virus, because I didn't mention that. I was talking more about chemical methods, but ultraviolet light disrupts the nucleic acids and essentially mutates them. But in a sense, it doesn't really fully destroy it. I mean, you're mutating that RNA, which in general is bad, but I think just using UV light alone, I think should be supplemented with other chemical methods, but that's not a definitive advice. Can humans develop immunity against coronavirus? And there's this issue of reinfection. That's an important point, which I will address a little bit later. But back to the whole mitigation strategy. I want to focus a little bit on the experience in Korea. And we had 4 lessons. Lesson number 1 is intervene fast before it's a crisis. It turned out that Korea was in some ways exceptionally fortunate and also unfortunate. Among the countries in the world responding to the Middle Eastern Respiratory Syndrome outbreak in 2015, Korea was arguably the worst prepared. And I think most people in Korea, even though it's not easy to say this, probably well realized that the efforts were not optimal in that case. So there was a lot of soul searching in the government, and in fact, the concept of never again, and there were specific factors why MERS was particularly bad in Korea. It's not a very transmissible disease, but it has about a 30% fatality rate, so it's transmissible in hospital settings. So they changed a lot of things in the hospital settings to minimize that transmission. And the other thing is the concept of testing, because if they couldn't find who was having the MERS, then obviously that can spread the infection. So there was a lot of emphasis on testing. And based on this bad experience, in December, there was actually at the Korean CDC a tabletop exercise gathering key leaders dealing with an actual simulated pandemic. Which is very interesting in Korea because in general, in Korean kind of business culture, you don't advance your career, you don't do a great job by mentioning how bad things can be. So that's obviously common. We've seen that not just in Korea, but I think it speaks to the leadership that at least some people were saying, you know, this could be bad. Let's imagine how bad it could be and do an exercise. And that's what was indeed done in December. So actually, as this was rolling out, they were planning some of these tests, and in late January, they developed the coronavirus test kits, which initially were actually quite interesting because they were general coronavirus test kits that subtracted out SARS and MERS and gave that a preliminary diagnosis of novel coronavirus, as it was called then, and then they further refined those tests. Another intervention very early on was there was an outbreak in Daegu. So that was containment. So actually we talk about the mitigation strategy, but there was actually containment strategy specifically with that outbreak. Lesson number 2, a lot of people talking about testing. And indeed, that's very important because that's the key to isolation and then also contact tracing and treatment, as we'll talk about. So Korea tested early, often, and safely. Over 300,000 people were tested. This was as of a week ago. They expanded the definitions of testing. So I think one of the big problems with the CDC in the United States, in addition to some technical problems with the test, is they had very constrained definition. Basically, only if you travel from China and you had significant symptoms would you even be considered for a test, and that was a big problem. There were 600 testing centers, so another issue is people showing up at the hospitals, and that was a big learning experience from Wuhan because there were no specialized centers to initially see patients or potential patients, and so everybody was going to the hospitals, and you had those overcrowded situations, cross-infection situations, cross-contamination, basically the worst of all possible worlds. And that was significantly mitigated through these separate 600 testing centers. Not listed on here was a separate phone number to call that would give directions to those testing centers. Those were eventually expanded to drive-through stations, as everyone has seen in the news, ultimately also to walk-in centers, as traffic issues and people without cars and so forth could be accommodated. And then in many places of work, hotels, office buildings, even restaurants, you had temperature screening at all places to screen out people who had a fever, and of course at the airports. So lesson number 3 is probably most important. Everyone says, let's do more testing, but testing without actually any outcome is not useful. So contact tracing, isolation, surveillance go together with testing. If you don't do those things and you just test, then it's essentially useless. We have a principle in medicine that you don't do a test unless you actually have an action item or something that follows up on that test. In other words, you don't just do testing for curiosity's sake. So that follow-up are things like contact tracing, both history, interview, closed circuit TV, credit card, GPS, where did that person go? Mass messaging, so all of us who live in Korea are getting emergency messages, not just saying, wash your hands and practice social distancing, but based on your location saying that there was a person, they don't give names, who is in this area who tested positive. They give a summary of where they were, and they say, if you have any possible contact or symptoms, call 1339, which is the number in Korea. Of course, surveillance related to those contacts, isolation, and apps that are provided for people who are in quarantine and isolation, and fines for violation. The fourth lesson was enlisting the public's health. There were television broadcasts associated with all the news, subway station announcements in English and Korean and Chinese, smartphone alerts, as I described, and continuous, transparent public briefings. This was extremely important. Daily, actually twice a day, public briefings by the Deputy Minister of Health or the Minister of Health themselves. So in addition to those primary mitigation strategies that I described, secondary mitigation strategies, building more hospitals is most familiar. China built a hospital in 10 days. And I thought this, when the news first came out in late January, was really telling, and I was very surprised that other people were not taking this seriously. If a country is building a massive hospital, actually several hospitals, in 10 days, there clearly is something going wrong. So when there was all debates in February, early February, well, this is like the flu, this is not a big deal, and so on and so forth. Not to politicize the situation, unfortunately, it has been politicized. But if you just look at that fact, why are people building these hospitals? Clearly, that means something is going on. So building more hospitals, and of course, we're doing that in New York, in Detroit, and other centers in the United States. Supply more ventilators. So there's the famous situation with Elon Musk. Medical triage in Italy and increasingly in the United States. They're now implementing ways that they can conserve ventilators, which is a euphemism essentially for triage, where people will not get that life-saving treatment because there's simply not enough. And so ethical decisions around that and medical authorities and so forth establishing that, that's the hard reality of this. And recruiting more healthcare professionals, so bringing people who are retired, etc. Now, Korea did something very interesting as well in terms of secondary mitigation strategies. I don't know the details of this, but healthcare workers are particularly prone to being infected because of the constant exposure, irrespective of the personal protective equipment, although obviously that helps. So then those healthcare people have two problems. One is obviously when they're sick, they cannot continue to provide care. And secondly, they can infect other people. And so I believe in Korea, many of these healthcare professionals are being put up at hotels near their hospitals so that they don't have to go home. Obviously, that sounds like a big hardship, but we hear about effectively the same thing in the United States, where some doctors are sleeping in their garages or in tents outside their home. I don't think that's the best solution, but at least, as I mentioned, in Korea, they're doing that hotel situation. So these are all the mitigation strategies, primary and secondary. I talked about quarantine. I talked about isolation. You know, we're doing all these things either in a systematic or a chaotic way, and it is what it is. But as has been alluded by many people, including Dr. Anthony Fauci himself, we can probably anticipate a second wave. This is the 1918, 1919 influenza epidemic. It was named after the 1918, where the King of Spain actually contracted it. But the second wave in the following winter was especially bad. And then again, later that spring, a third wave that went through the population. I think all indications are, given the biology that I described about this virus, its long incubation period, its a large proportion of people who are asymptomatic, and the lack of isolation. In fact, I should say the impossibility of isolation, that a second wave and a third wave, and indeed the multiple waves, in other words, the disease being endemic, are extremely high likelihood, if not virtually assured. So this means that before Corona and after Corona situation is not going to go away in any foreseeable future. And that's a big problem because obviously everyone's life has been changed. So we have containment, mitigation. What's the next step? The only answer, as I see it, the only definitive answer is a vaccine. Now, I know that that sounds like a platitude, and everyone says, well, they're working on it, 18 months, blah, blah, blah. And I think obviously these are very important efforts, but I do not think that enough thought has been, or effort going into a systematic global Manhattan Project for the atomic bomb or the Marshall Plan type of thing to develop a vaccine. There have been reports of Johnson & Johnson and Moderna and that, isolated labs. I have not seen anything truly concerted, both in terms of effort and money in this regard. So I'll talk about that shortly. I'm finishing up the presentation, and then we'll have a more extended discussion. So there are several vaccine candidates: a viral vector vaccine, where we put the genome into another virus, and that creates the proteins that the antibody can act on; a DNA vaccine, an RNA vaccine, a live attenuated vaccine, which is the most common approach, a protein-based vaccine, and finally, this is the convalescent serum, which is not exactly a vaccine, but giving a passive immune response. So there are many different candidates. I suspect, given the mutagenesis, the urgency of this, that multiple vaccine possibilities may be necessary. We have to think out of the box. Maybe people get two different vaccines. Maybe there are two different approaches. This is speaking from the scientific aspect. So let's look at the $2 trillion stimulus bill. I think the global amount is maybe $5 or $6 trillion that various governments around the world have put in. So I'll ask another question to the audience. How much of this $2 trillion stimulus bill is going to further advance vaccine research for this condition? Let me see your answers, please. 300,000, 500,000, 500 million. Not enough. 0. 1 million, 2 million. Not clear from the bill. 0. 0. Less than 1 million. 0. 10%. Okay, I think people are getting some idea. The answer actually is 0. Now there is, I've read the bill. It's not easy reading, but if you want to go to sleep, if you're all anxious, you might want to read one of these bills. That's a good mitigation, I guess, for insomnia. But anyway, there's 0 for developing a vaccine research. There's actually some money related to, or some measures related to insurance coverage of vaccines and tests and free tests and whatnot, but there is no expanded research allocation or appropriation, at least in the United States budget in this regard. So it's zero. Where is that money going? It's going to public health measures, forgiving or deferring student loans, cash payments. That's the famous $1,200 that American citizens are anxiously waiting for, extra unemployment payments, bailouts, small business loans, support to state and local governments, and various smaller things. That is the $2 trillion stimulus bill. So in other words, the definitive solution to this crisis, because we know it's going to come back, we know it's certainly affecting everybody now, the definitive solution to this crisis is not being addressed in any substantive, coordinated, intensive way, in the same way as we developed the atomic bomb, in the same way as we went to the moon, in the same way as we tried to rescue various countries after the devastation of World War II. And I think that's, to put it mildly, a big problem. And so we have a wide variety of people in the audience here. I think one of the things we can all personally do is various safety measures, some of which are described here, some mitigation measures, but somehow if we can get the message out about vaccine development. Now you might say that's sort of obvious, but as I mentioned, this vaccine development will be not just the science, which I described, not just the biology, but aspects of governance and infrastructure. How do we distribute it? How do we deal with the side effects, the indemnity, or whatever, all these other aspects, social, cultural, governmental aspects related to vaccine development. It's not just coming something out of a lab. Obviously, research and development, emerging technologies related to this, engagement and communication. We have a big problem with anti-vaxxers, with lack of information. And so very powerful public relations and engagement are very important. Social sciences, ethics. Obviously, things have to be done ethically, but we have to think more broadly on how to expand this and do it quickly, do things in parallel, and compensate people for any adverse issues, all in the sake of moving this forward more aggressively. So this is actually was published in Nature, a comprehensive approach to epidemic response across the whole spectrum. It's not just about cash payments to individuals. It's not just about, just having a pandemic response team. All of these are important, but I think an integrated approach to epidemic response, I think, is something that we must be doing. So I'll ask the audience here, what is missing from this? This looks very comprehensive: governance, infrastructure, R&D, emerging technologies, engagement and communication, social sciences, ethics, integrating the environmental and the ecological. What, in your mind, is missing from this comprehensive epidemic response? Any answers? By the way, someone said the best coordinated and funded vaccine effort I've seen to date, Gates Foundation, Optimus Coronavirus. I think that plays a role, but Bill Gates, wealthy as he is, and so forth, I think we need, something even beyond that. I mean, one foundation alone can't be doing this. We need a global, worldwide effort, not just the WHO, but some sort of leadership in this regard to have a Mars shot type of effort. So obviously people are working on this, but I think everyone has to stand back and think about it in a much more aggressive way. So money, leadership, military infrastructure, global cooperation, what is missing? coordinated leadership, individual response. Okay, these are great answers. I will just pipe in because we're already past an hour. I'll tell you a quick story from medical school. So I was applying to medical school. I took the medical college admissions test, and there was an essay. And I don't actually remember the question, but I remember my answer to the essay. So this is 35 years ago. And my answer was, they were saying, how do you change the healthcare system, or how do you change something? And I don't know exactly what the question was asking to change, but my answer was the most sustainable, most effective way to change things is through education. So I think one thing that's missing from this very nice comprehensive chart, which I think is all good, the one thing it's missing is education. I think we lack fundamental medical education, health understanding among people and among leaders and among policymakers. I didn't want to put people on the spot, but all of you are top level professionals. I know this. KBLA, obviously, its mailing list and attracts leading people, but quite frankly, not all of us knew if a virus was alive. Many of us may not have known that antivirals don't actually kill a virus. And there are many cases. And of course, this lack of knowledge translates into fear, uncertainty, poor policies, no policies, etc. So I actually think we need a more worldwide education and health education. When I was in junior high school, we had some health education. I don't know if that's still the case with youngsters around the world, and certainly professionals. But and I apologize this to Rodney, but I just want to say that I'm trying my best to implement this. So this is not a personal plug, but I teach a mini MD around the world. I put it online, or I'm in the process of putting it online. It's the mini MD, mini medical school. So it's a personal passion of mine, because I think the more we know individually and as organizations about medicine, we tend to look at it as a black box. And I think doctors are sometimes guilty of that. Doctors only should know. People kind of in the dark, and they can depend on doctors and so forth. And I'm not saying it's on purpose, but I think this shared knowledge, shared understanding of health, the complexities of the healthcare system, and how everyone contribute. I think ultimately we need a global effort on health education. And that will, of course, support and mitigate, support vaccine development, mitigate the anti-vaxxer movement. Better medical knowledge is going to be central to solving this and future challenges. So I'll leave it at that. Thank you very much. Please take care. This is my email. I'm also on LinkedIn. Feel free to send me an invite if you are not already connected to me. And Rodney, if you want to moderate, or I can just answer the questions that pop up on the chat window. Thank you very much. And I believe we have some more time for questions.
This is the discussion period, so go ahead and send out any messages that you'd like to have Dr. Gurel address, and ask anything about the virus, anything about Korea's responses. We can probably expand it even to business and organizational responses if necessary. Whatever questions come up, we can try to answer.
I know some of you have asked questions in passing. Obviously, I couldn't read all of them. So if you want to ask those questions again, because I don't want to waste people's time just scrolling through these. So I apologize if I didn't answer every one. I was just scanning them on my screen here, you can see. But if you want to repeat them or ask new questions, feel free to do that now. The first one, can you forecast what the summer months may bring in terms of international travel? You know, a lot of people talking about the weather, and this is actually interesting. I didn't talk about this in detail, but these coronaviruses likely to be slowed down with warmer temperatures. Uh, so there's a lot of hope that it will disappear when the weather gets warmer. Well, there are two problems with that. It's not completely disappeared, typically, as flu is also adversely affected by the warm weather, but then it comes back every winter season, as we well know. And then, of course, we have two hemispheres, southern and northern, and so this has the capability of being maintained in that regard as well. Another interesting implication to this is early on when Singapore started to get some cases. By the way, it's very warm in Singapore all the time, but they have had cases. These cases were contracted or transmitted in hotels and shopping malls. And has anyone been to, if anyone's been to Singapore, it's a very hot, you know, basically tropical environment, but the hotels and shopping malls are absolutely frigidly air conditioned. I mean, it's freezing in those places. And so that probably helped propagate it. And I know that the Singapore authorities had implemented measures to tone down the air conditioning. So that might be an important measure. If you're in a very hot environment, you're using a lot of air conditioning, you want to minimize that transmission in some marginal way, reduce your air conditioning. So to the point about air travel, I don't think this is going to go away. I think this is going to change human life, including travel and how people meet for the foreseeable future, including this summer. I don't see significant bouncing back. And that's why I say a vaccine is the only definitive solution. So lots of questions here. Let me answer them more quickly. I think Paul asked, why was the Imperial College study taken down the web? He asked that before. I really don't know. I think there has been some concerns that perhaps data was overreacting or whatever, but I think I can't speak to what those reasons were. I think it's a very fast evolving situation. The medical mindset of mine, the surgeon mindset of mine tells me this is not a hoax. This is not just the flu for the reasons that I argued. It does have significant mortality, significant morbidity. So the precise numbers will be changing on a day-to-day basis. But, you know, people do surgery on the basis of limited data to save a life, whether it be appendicitis or expanding blood in a brain bleed or whatever it may be. You don't dot all the I's, cross all the T's. You know the patient is going to be dying, and you act on that. So I think that that situation is changing, and perhaps it was taken down that they didn't feel it was 100% accurate, whatever. I don't know the answer to that. Can laymen make their own hydrogen spray? I think you take about 3% hydrogen peroxide, not hydrogen, but hydrogen peroxide, I guess, and just combine that with water. In Korea, we do have dedicated hydrogen peroxide sprays. How is compliance met in Korea with so many countries have failed? So that's interesting. I think there's a fairly stronger group spirit in Korea. So when people are told to contribute for the greater good and do certain things, I think there's a better sort of compliance with that in general. I should say, though, that I've been a little bit disappointed lately. I think in Korea I think some people have gotten to a very self-congratulatory state and say we're the best. People like us, and we look very good, and it doesn't matter how you look, it matters how you respond to the situation. And I've seen some degree of complacency. I'm not the only one that have commented on that, especially in the regards to new cases coming from the outside and the second wave concept. So The government has implemented extra strict quarantine on people coming from the outside. So I'm not saying it's completely complacent. On a public level, I'm worried that might be the case. On the other hand, that's just human nature. I mean, people can't be isolated indefinitely. Compliance tends to, devotion to compliance tends to wane. So these are all factors that need to be taken into account. Do you have any update on the virus mutation, whether effective vaccine can be developed? That's a great question. So I've argued that vaccination is the only solution. But then I also said that because it's an RNA virus, it can mutate. So that indeed is a challenge. So you might say, well, this is a pipe dream. HIV, we haven't had a vaccine for 20 years, more than 20 years, of course, 30 years. So how are we going to get it in the near term for coronavirus? Well, there's two important differences between HIV and coronavirus. They're both RNA viruses, but HIV is a retrovirus. So it goes from RNA to DNA and then from DNA to RNA. So its mutability is actually quite high. So HIV mutations develop a lot. Coronavirus mutations also happen a lot because it's an RNA virus. But the second difference is that HIV is a very scary virus. It's not as transmissible, basically just through bodily fluids, including blood. But it's a very scary virus because it attacks another vulnerability in the body, which is essentially the cells that control the immune response. Coronavirus attacks another vulnerability in the body, which we described. That vulnerability is not the immune response, but rather the basic cardiorespiratory function. That's why it's so potentially fatal. And the fact that HIV affects the immune system makes it uniquely difficult to make a vaccine. In other words, the vaccine recruits the immune system to fight the virus, but if the virus is infecting the immune system, that complicates things and may indeed make it almost impossible. A coronavirus, fortunately, does not infect the immune system, so that people have developed antibodies to coronavirus. They've also developed antibodies to HIV, but as I said, the immune system is not as able to clear it in that context. But coronavirus attacks a very specific vulnerability, but not the immune system. So I think that there is possibility to develop a virus. When I said multiple approaches to the virus may be necessary, this was in light of the fact that there is some mutability to the coronavirus. So I think that it would be a mistake, and this is just a personal opinion. I am not a virologist. I'm not a vaccine specialist per se, but I think that multiple approaches to the vaccine should be necessary. We know this to be the case with hepatitis, for example. People get 3 vaccines, first one, then one in 6 months, then another one, another 6 months to 12 months. So spread over time, or multiple types of vaccines. We have to think very open-mindedly. But I do think fundamentally a vaccine is possible in contrast to HIV. So education is important. Changhan asked focus on content rather than attitude. Yeah, I believe that attitude is very important. I mean, education is not just translating information. It's getting people committed, passionate, interested. That's the essence of education. Will other countries, not the US, be able to introduce vaccines earlier due to fewer regulations? It's very interesting. I think that the United States is quite interesting. It is a very dynamic, free, open society on some levels. It is also an extremely brittle, over-regulated, over-cautious, locked-in country in other respects. And I think healthcare is a particular vulnerability in the United States in this regard. So there's a lot of monetary interests and regulation that maintain a certain status quo in the United States. I'm not saying that's all bad, but I think it's created a unique situation in which it's very difficult to make some sort of progress. So I do think that a vaccine effort should be a global effort because I think there is innovation and clearly brilliant people in the United States, but I think there are some impediments. So we need to have a global effort in this. Could the U.S. disaster have been avoided? Well, I think avoided may not be the right question or my point. I think everybody's having a disaster. It's a disaster, quite frankly, in Korea as well. It's less of a disaster. So I think that's important to keep in mind. Could the U.S. disaster have been less? Undoubtedly, yes, because as I mentioned, Korea had the pandemic training, it had tests, it had a system, it had a coordinated information. I think there are a lot of good things in the U.S. system, but also unique institutional vulnerabilities, fragmentation, lack of information sharing, and so forth that made it difficult. With the second or third waves to hit later, do you expect to go in order Asia, Europe, to North America? I think it's very hard to predict. I think the waves will probably be related in general, less to temperature patterns and so forth, probably to how effective are the mitigation strategies. And by the way, harsher mitigation strategy may not necessarily translate into less of a second wave, because we have to think of the big social context. If you have a very harsh mitigation strategy according to Rodney's framework, there's going to be resistance, and if that suddenly resists, people are fed up or whatever, and you get the opposite, even though you had very stringent strategies in that one case, that could be higher risk for a second wave. Any new outcomes results on patients receiving Plaquenil Z-Pak therapy? I think, as I mentioned at the outset, there are no magic bullets, whether it be Plaquenil, Z-Pak, or anything else for that matter. There is no such thing as an antiviral. These will just mitigate it, which is okay. But I think a lot of discussion on let's find that one drug that will eliminate this and do all the trials and really develop that and devote resources, when as just a matter of science and a matter of logic, it's only going to marginally affect the situation, I think is less than helpful than I mentioned, as concerted an effort as possible on vaccines. Now, obviously, we have to do things at the present time, but the epidemiological measures, especially around testing and isolation and social distancing, are probably more effective than any marginal drug therapies can do. People on ACE inhibitors for blood pressure, should they stop it? I think that that's very difficult advice to give. I think everybody has to be communicating with their doctor on their individual situation with regard to ACE inhibitors. But clearly, the ACE system and its influence by ACE inhibitors is a very unique vulnerability point with respect to this virus. So I think my best advice is you should have that discussion with your doctor on that, and your doctor should, if they have a lot of patients on ACE inhibitors, should be studying that situation, as opposed to just saying, well, I don't know anything. So it's both the patient and the doctor, but I can't give any specific advice on that. Why are there so many cases in Singapore and Philippines? I don't know what the question is. Chang Han saying, how much Korean do I read or understand when spoken? I assume he's saying that because I don't speak Korean or perfectly, then I'm not qualified to comment, so I will leave it at that. Does IVIG help positive cases recover? I think there's some evidence that convalescent serum or antibodies from people who have recovered have had some effect, and that's, I think, encouraging, not because it's helped those patients, which is of course important, but because I think it indicates the possibility effectiveness of a vaccine. So why did I discount the importance of that? Obviously you want to save lives, but I think it's extremely complex to get this convalescent serum. It's not easy. We should, fully investigate this, but it's a really stopgap measure, and I think we should really focus as much efforts on a vaccine as much as possible. Is the load issue true? Degree of exposure influencing degree of symptoms? Yes, I think so. I think the fact that healthcare workers who are clearly exposed to more of the virus will typically get more easily infected. In fact, some of the young people who have died have been the healthcare workers. We know famous cases in that regard. So I think viral load is quite significant in this case. I don't know if we know the mechanism exactly. It might be related to the slow sort of replication, the long incubation period. So if you have a slow replication, which is bad because it increases the transmissibility. It's also good because if something's replicating slowly, then the immune system can stop it. But if you have a slow replication but a high viral load, that can obviously, how should I say, the virus is at a much faster starting point, so the consequences can be worse. What public health measures are being put into place in Korea to prevent or mitigate the second wave of infections? I'm not aware in particular of any, but I think obviously an expansion of, or continuation, I would say, of what's being done now. How about Africa? We are seeing some cases increasing in Africa. I think that's indeed right. I don't know the details of that, but clearly, as I mentioned, it's not the virus alone that's the problem. It's the virus in connection to healthcare systems. So if you have very vulnerable healthcare system, the virus is going to be worse. So their levels of infection may very well be less, but that doesn't mean that it's not going to have a big impact.
Ogan, can I jump on for a second?
Yeah, please.
On the previous question about public health measures being put in place in Korea, the issue here is actually we've become very good at creating criteria for enacting different measures, but we haven't really taken a lot of time to discuss criteria for backing off on those measures. And if the government has criteria, and when the government's out there looking at the incidence rate, the testing rate, currently to today, 410,000 people in Korea have been tested. Out of those 410,000 people, 97.5 have tested negative. So it's an enormous number of negative hits for every test that they do. And the testing has been pretty constant up till now. So if there are criteria that the government's looking at, we don't know what it is, but we know that they are not seeing what they want to see, because schools were supposed to begin on April 6th of this year, and they have now been postponed until April 9th. And April 9th, they're going to actually start online education. So the government itself hasn't made any significant steps to back off on previous measures. We just came off of a 2-week time period in which more concentrated social distancing measures were being recommended in order to get the number of daily hits down to a level where they could start to back off on those measures. Yesterday, the decision was made that no, they're not going to do that. They're not going to let kids go back to school. They're going to instead start online education on April 9th. So that tells you that whatever it is that the government is looking at in terms of a decision criteria to back off on those measures, it hasn't seen it yet. I don't know what the ultimate decision will be. and when it will come. But this is a question that every country is going to have to eventually come up to deal with: is how do we walk it back? What are the decisions that we're going to have to make in order to say, okay, now it's safe? Because if children were to go back to school, if we were able to open up certain establishments, have larger groups, go back to having, you know, public sports, for example, and the number of cases suddenly spike, then we'll have to go back to the previous measures, and maybe we've actually missed our chance. Maybe we'll have to go to worse measures than we previously had, and then backing off later will be all that much more difficult. So it's very important for the government to get it right the first time, and I think that's why everyone's being overly cautious on this. Thank you.
Yeah, thanks a lot to Rodney. So there's a lot of unknowns that influence decision making. I'll answer a few more of these questions.
I just step in and comment on Rodney's point.
Yeah.
Just to let you know that, you know, the Korea's 확진자율, I don't know how to, you know, the percentage that gets actually confirmed as infected from the test. So at the end of February, it was around a little bit less than 6%. It's like 5.67%. But then by the end of this month, it came down to less than 2.5%. So we have seen this trend. As more people get tested, obviously the number of or percentage of infected gets down lower. But like Rodney says, you know, it's not clear whether this is the kind of the criteria that the government is looking for, or are they just looking at the number of new cases and whether or not that number needs to be sufficiently down for them to start, like, for example, going back to normal sequence, normal life. So anyways, that's just a
Who was that comment?
This is Richard Shin.
Richard, thanks a lot. Yeah, that raises another very interesting point, which we started talking at the beginning about the fatality rate. And I was saying how the statistics are not precise. So in Korea, they were testing based, for example, they completely tested all the people with Shincheonji, and unrelated to whether they had symptoms or didn't have symptoms and so forth. And then, of course, all those were tested. So the criteria for testing have changed. So that makes it, I think what you pointed out, statistics, you know, very good. And there's some interesting trends there, but it also makes it very hard to compare. Because if your criteria for testing is suddenly changed, then the percentage that are positive is going to reflect not just the actual number of cases, but also your criteria as they changed. So this is also, for example, we saw this in the diagnosis of COVID. About a month ago, I think it was early February, the first week of February, in China, they changed the criteria for the diagnosis of COVID away from the test, but actually to a CT scan that showed the characteristic ground glass opacities, which are reflective of the fibrosis I mentioned. And that suddenly spiked all the numbers. So suddenly, and you'll still see that if you look at the worldometers, you'll see this bump up that's related to a totally arbitrary, well, not arbitrary, but change in criteria. So I'm not saying that we can't make decisions, but because of lack of precise data, but this is a very moving target. So it is difficult to make these comparisons.
It's also a rear view mirror. We're also looking at data that's, you know, that is the result of actions that we have taken a week ago, 2 weeks ago. So even though Korea went through this 2-week period of very stringent social distancing, that won't actually come out in the data until next week or soon. So what we're looking at, and it makes it very difficult for us to link mentally the actions we're taking with the data that we're seeing.
Yeah, so you see worldwide, the numbers are continuing to increase exponentially, but clearly economies have collapsed and social distancing and lockdowns have happened for over a week, 2 weeks, even 3 weeks in many places, and you don't see the effect, but that's more tests rolling out. So there's a big disconnect, and that's a big challenge in terms of public health, because people are doing all these measures, but the numbers are not going down. But we're just seeing these in retrospect, and also as an artifact, if you will, of the increased testing, which is important for the reasons that I mentioned, but they actually increased the numbers that seem to fly in the face of what everyone's trying to do. So let me go through some more questions, if that's okay, Rodney, or what is your plan? You're the host.
Please, more. I think there's several questions that we haven't addressed.
Okay, two people asked, does ibuprofen really exacerbate the symptoms? So this is a very interesting question, important question. So first of all, I should say, again, we don't have definitive data. There's been sort of two sides to this, and like anything, it sometimes has even gotten politicized. Obviously, I will stay away from those matters. And I will say that, again, it's important that your individual case be coordinated with your healthcare professional. But the whole issue of inflammation and the immune response. So what's interesting about the flu is when people die of the flu, and it's rare, it's 0.1% mortality, it's typically older people, they typically die of either two things. One is some sort of secondary bacterial pneumonia on top of the viral pneumonia, or an overwhelming immune response that leads to what they call a cytokine storm inflammatory response. So reducing that inflammation has been shown to be somewhat useful, whether it be simple methods like ibuprofen or more sophisticated methods like various interleukin therapies and whatnot, useful in the flu. I think the increasing feeling is that this whole inflammatory response, cytokine storm concept may be a little less applicable to COVID-19. In other words, people die more of a direct viral pneumonia that directly damages the lungs, complicated by this blood pressure going awry related to the fact that it's the ACE2 vulnerability, rather than a cytokine storm. So then people have been thinking, well, the anti-inflammatories, they're not helping mitigate the cytokine storm, but they could be reducing the immune response, which is ultimately clearing. So perhaps people might be doing worse on ibuprofen. So that's been sort of the feeling by some doctors, as well as the WHO, on and off and so forth. So my personal feeling is that ibuprofen is probably not such a good idea. You want to keep your immune system as strong as possible and your inflammatory response as strong as possible. But again, individual decisions should be made in consultation with your doctor. So Yuri said we should take lessons from Singapore. No significant numbers detected at the school opening. I think Singapore is a very special case. It's a very warm climate. It has this air conditioning issue. As I mentioned, they've actually tried to tone that down. And they've done many good things, I think, but for many temperate climates, extrapolating from the Singapore experience alone and saying, why don't we like Singapore, can be a little bit dangerous. I think it's better for places like United States and Europe to follow the South Korean example. Not that there are significant differences, but I think if you want to avoid comparing apples to oranges, Singapore it's good to get best practices, but South Korea might be a better, more comparable test case. Should the WHO issue the criteria for de-escalation? This may be a little bit sounding political, but in principle, I think the WHO should play a leading role in this. But in practice, I'm quite concerned that the WHO, particularly its delay in declaring this a pandemic when it clearly was a pandemic, to even the most minimally aware among us, I think has been a challenge. And I don't know what transglobal, transnational organization will have the right authority and credibility to do this. But I'm very concerned that the WHO has abrogated some of that. Don't know how to answer more definitively, but indeed, if we had some global criteria for de-escalation, that would be very helpful. But if the WHO says, now it's time to de-escalate because of certain criteria, not sure how impactful that will be. Somebody wrote about vaccines with eggs. Are there any new ways? Yeah, that's actually a good point. I mean, there's lots of aspects to vaccine development. So there's the basic science that the scientists want to talk about, but then there's the whole scale-up, delivery, distribution. So I think when I talk about a global worldwide effort, it's not just about some people in some labs, which is extremely important and of course necessary, but how we produce it. There are methods using eggs for the flu vaccine. Are there other ways we can do it? Are there other ways we can ramp this up? For example, having other viruses that replicate to produce the vaccine. Of course, there are also dangers, but we have to think out of the box about other methods. What is the main factor in the speed of the spread in Italy and Spain? That's a very interesting question. I've thought about it as well. I think what's interesting in Korea is we've had fairly effective mitigation. Korea is quite a group-oriented society, and I think that people like to get together. It's a very group-oriented culture. I think that's very clear, and there's a lot of nice and charming aspects to that. I think that obviously puts the society at risk. People like to be in groups, and as I said, I think there's been some complacency. I've seen people in the parks gathering in this way. On the other hand, even though Koreans may gather in groups, they don't tend to be hugging and touching each other as much, perhaps in Southern European countries where it's more of a culture, kissing and so forth, even among relative strangers. And I'm not saying that's exclusive to Spain and Italy, but it was quite remarkable and disturbing how it spread so rapidly, and some of those cultural factors may be at play. But I think Korea has to be very careful because it is a very compact, dense society. People do like to congregate. That's just natural. If you go out during lunchtime, during normal times, you see all the office workers going to lunch in a big group, sitting together in a big group, albeit they may not be touching and kissing and all that, but that still is a risk. So in Korea, we have to be very careful. I think it's very unfortunate. A lot of cultural characteristics will be changed or have to change for the near future. Of course, when it comes to Spain and Italy, there are also issues related to their aging of their populations and other factors. So I don't want to comment on one aspect, but in terms of rapidity of spread, I think cultural aspects are very important.
Can I jump on here real quick?
Yeah.
I think that next time around, everyone is going to do better.
Oh yeah.
That's important because if you look at the responses in Asia, they were all fairly effective, and some more effective than others. And the fact is that Asia has had practice,
Yeah, right.
very serious practice, very relatively recent practice. And the leadership has learned from that experience and has now brought that experience to bear to some effect. If you look at Taiwan, Taiwan actually was the first country to implement restriction on travel from China, and they did so on January 31st officially, which was before China even admitted to having a problem. So Taiwan was so sensitive to the signals that they were receiving from the experience that they've had from prior times, and that they already had put in place a process. They'd already put in place a plan that gave them the option of heading this off at the pass, that a lot of other countries just never had the option. The option was, it was never in their cards for them to be able to react that way because they had never done it. It's a learning process. I guarantee you next time this happens, everyone will act differently. And that's, as Dr. Gurel said previously, a function of leadership. The first time you react well, second time you let your guard down, third time you react well again, because of the experiential roller coaster that countries go on. The first time they get burned, they respond, and organizations do the same. They get better. Then the next time they got better, but they think that the crisis wasn't such a big deal because the impact wasn't so great, and they forget that that was a result of their preparation and their activities, and they end up with a worse result, and then they prepare better, and next time they do better. So I think that if you look at the countries in Europe and the US, they started from a completely different place, a completely different point of view, and a completely different set of considerations. So in Asia, they've been burned, especially here in Korea. We've had bird flu, SARS, MERS, all of these things relatively recently, and have learned a lot from those experiences.
Yeah, I should add about those experiences more specifically and their intersection with cultural aspects and so forth, and lasting change in education. So in Korea, we have a very nice system that most buildings have public bathrooms. And so if you're going around town and you have to go to the restroom, you can pretty much find that in a public building. And generally they're not locked off. You don't have to buy a bagel to get in there, and all sorts of other shenanigans. So after SARS in 2003, there was a very concerted effort to have soap in all those bathrooms. And before, it was sometimes there, it wasn't there, and so forth. But now if you go to bathrooms in Korea, and of course this is 20 years later or more, or whatever, it's since 2003, you'll find soap in the bathrooms. That has been a complete cultural, societal change that came out of SARS. Another example is the MERS epidemic, which hit Korea worst among developed countries. MERS, by the way, is still endemic in the Middle East, and so it can pop up. But it's a very deep respiratory virus, does not get transmitted easily, but it's very fatal. And it's only transmitted, I should say, it's because it's so difficult to be transmitted, it's generally only transmitted in hospital settings where people are on ventilators, they're getting pulmonary procedures, intubations, bronchoscopy, and so forth, that release the droplets, and et cetera. So Korea had a very interesting medical culture where people in the hospital, it was expected that their family members are with them. They're actually taking care of them, not medically, but in a non-medical way, bringing food or feeding them and so forth, which actually has a very big positive effect. Patients have psychological support. They're not as alienated, isolated, and of course, the less demands on the healthcare system for resources, et cetera. But that turned out to be a big vulnerability. So the fact that all these family members were around and so forth was one factor in the propagation of MERS in Korean hospitals. And of course, that practice has not been completely curtailed, but with the quick testing and so forth, as I mentioned, that cultural aspect, and I don't mean this as a better culture or a worse culture, because people get into these issues, which is better or worse. That cultural aspect has been managed, and we don't have as much of that risk anymore. So in Korea, we've had these experiences. We have changed, and as Rodney mentioned, I suppose in other places, we hopefully will learn from these experiences with the right leadership to guide that. So I think some of these questions are fairly technical. What is the main reason for vaccine development? About 18 months, is it regulation, lab testing, something else? I think it's a whole serial sequence of activities. You have preclinical development, you have animal testing, you have phase 1 trials, phase 2, phase 3 trials, scale up, etc. I think the more we can do in parallel with multiple countries. Part of the problem with phase 3 trials, it takes a long time to get the thousands of patients to test it on. The bigger we can do this Manhattan Project, perhaps $500 billion project, whatever it may be, not a few million here or there, we can accelerate that. So there's no one answer to that in that chain of events. Will establishing the exact route of zoonotic transmission, intermediate species, do anything to speed development of vaccine? I'm not clear, what effect that will have on vaccine development. Don't exactly know the context of that question. Rodney, I think we're near the end of the 2 hours.
Yep.
Yep. What incentives would pharma have to quickly develop vaccines? I think vaccine development is not just pharma. I think many people have to be involved. So obviously pharma plays a role in this, but many groups have to be incentivized. Distribution, delivery, the healthcare workers. Just giving more money to the pharma companies is not the only idea. Obviously, they need to have some incentivization, and we have to work that into it. But everybody has to be incentivized.
Okay, let's end it here. And I'd like to thank Dr. Ogan Gurel for all his incredible insights and his work in putting together this presentation. I know that this doesn't come easy. It's usually an hour a slide or 2 hours a slide at least. So I'd like to thank him and thank the Canadian Chamber of Commerce and also everyone who participated. Thank you. We'll end it here.
Thank you, Rodney.
Thank you very much.
You have my email there if anyone wants to follow up.
Thank you so much.
Thank you.
Very good presentation.
Thank you.
Thank you.